So this month, we're very excited to have Dr. Stephen Jones from Cleveland Clinic. So let me do a very brief introduction. Dr. Jones, although, I think everybody probably know him pretty well. So Dr. Jones is the endowed chair in neuroradiology research and the vice chair for research of the Imaging Institute at Cleveland Clinic. So Dr. Jones got his undergraduate degree in physics at Caltech, and then went to graduate school at Cornell University and earned a Ph.D. in nuclear fusion. And then he switched the research fields to X-ray actual physics at MIT. And then after that, his scientific interest then migrated from astrophysics to neuroscience. And he then went to a medical school at Tufts University in Boston. And then he did all postgraduate graduate education at MGH. So today, as we know, his research interests are centered on brain function and brain connectivity, including advanced technology development and applications in different diseases such as epilepsy, neurodegenerative diseases, multiple sclerosis, and many other disorders. So in 2003, he developed the clinical 7T MRI program at the Cleveland Clinic. And more recently, he also developed their high intensity focused ultrasound program. So today he's gonna talk to us about the clinical 7T at Cleveland Clinic. So I was gonna say, looking through this, all these research experience, what a career! I was wondering maybe someday I can invite you for a talk for nuclear fusion. But today I'm looking forward to your talk on clinical 7T technology and applications in different diseases. So thank you, Dr. Jones. Looking forward.
Well, thank you for that nice introduction, and thank you for inviting me to come talk to you in your center. As you can gather, I wear kind of two hats. I wear a research Ph.D. hat, and I wear a Dr. M.D. hat. It doesn't make me actually better at either one, but I'm in a good position to see the questions that doctors raise and then the techniques that are in the laboratory. And I'm excited to kind of be able to show you some things that come from that, and hopefully can cross it over to show you what are the clinical applications of, as a doctor, how do we use this? And this is going to be a talk with lots of pictures because I want to convey to you the imaging aspects. There's going to be an outline, a little bit of introduction and context, and then we'll spend a bit of time on epilepsy cases, probably the majority of the time, and then just touch a little bit into multiple sclerosis, some vascular applications, some really interesting, cool cases that we've seen ex vivo, and then we'll conclude. And then I also just want to give a shout out to my colleague, Irene Wong, who's here at the Cleveland Clinic, and she's going to be talking to you guys in about 2 months. And she's going to kind of pick up where I've left off, where I'm going to be really very clinical and picture-oriented. She's going to talk about more advanced topics that extend with 7 Tesla. So why is 7 Tesla better? And I'm sure everyone knows that, we're going to get more signal, and we can use that signal in different ways. But as a physician, how do we use it? What's good about it? And in the end, I think in the star there, it endows us with smaller voxels, so we can get higher spatial resolution. And it also allows improved tissue contrast. And there are a few other things like, the increased bold effect for fMRI and increased susceptibility effects, and we'll show you a little bit of that. But I always think of it's the high spatial resolution and improved tissue contrast as a physician is what helps me with that. And if you're ever interested, this is was a fun thing we did. I think the same person where we did the same sequence at 3 Tesla and 7 Tesla, meaning that same voxel size. And the question was, what does increased signal to noise look like? If we spend all that signal just to make something smoother, and this is what you get. Now, as I say, as a radiologist, what's on the right-hand side of the 7 Tesla, it's very nice, it's very smooth, but in a way it's kind of overkill. I don't need medically to have something quite so smooth to make a medical diagnosis. So maybe we can go with smaller voxels, for example. We can see differences in the contrast to noise. And for epilepsy, what we'll look at is that gray-white junction. I don't know if, hopefully you can see my little mouse here. And what we're looking for are changes in that gray-white distinction to help with the diagnose the disease of epilepsy. And we all know about the problem with 7 Tesla. You can get a lot of signal dropout near the base of the skull. And this is a fixable problem that is currently being worked on too. So the gray-white junction we talked about, this is a 3 Tesla and a 7 Tesla, same patient. And it'd be nice to see quantitatively or mathematically, what is our eye seeing? Because I think we'd all say that the gray-white junction is sharper here. And in fact, and this is with Irene, is we can take a profile along that little blue line and just kind of put into a graph what our eye is actually seeing. That across, for 7 Tesla, it's more flat, more uniform across the gray-white. This is the gray matter here, and this is the white matter. And then you have a steeper transition. So this is what our eye is detecting when we say that there's improved contrast with gray-white junction. So let's get into epilepsy. So this is a 21-year-old female, medically refractory epilepsy. The seizures were getting worse, and it's kind of typical, and I'm sure you guys see the same story over and again, is that all the prior studies were negative. And so shown here at 3 Tesla, you can barely make out that blurred blob there. At 7 Tesla, sure enough, you could see that there was some blurring of that gray-white junction right here. And in retrospect, if you go back, you could kind of see it. Now, I want to just say clearly at the bottom here, I admit you need to be able to actively scroll back and forth in window to really appreciate these small lesions. And trust me, I've sat in audiences many a time where I'll see a speaker put up epilepsy slides and say, hey, did you see it? Did you see it there? Well, it's going to be very tough. And you might think, man, that's what, and you have to be able to sit at a console, I admit it, and window, scroll back and forth, do convolve in your head what might be partial averaging or not. But this was one of our early home run cases with 7 Tesla, and it was laser ablated, and this young woman has been seizure free. And imagine, the import of what I just said is that epilepsy, for research, this gets me excited because in epilepsy, it's a disease often with younger people. It affects them drastically. They can't drive, have trouble holding jobs, relationships. They've got trouble with medications. And you can make a big home run here as a researcher. If you find ways to see these tiny little lesions, you can get someone here at an early stage of life and really alter in a very positive way. And I find that very exciting about epilepsy, is to do this, where you kind of a result. Here's another patient, an 18-year-old female. Again, prior MRIs were negative, intractable epilepsy, 1.5 Tesla, and maybe there was something here, but clearly the 7 Tesla showed you the subcortical tail that was there. This is a quality is not very good, showing you the sagittal, and you can indeed, if you knew a little bit before, there's a blur there, and was confirmed at 7 Tesla. Same kind of a story. We dissected, and this woman has now been 7 years seizure-free since we last checked. Here's a 27-year-old medically intractable epilepsy. I'll just let you look at that for just a second. Do you see the lesion? It's in this area right here. Again, it becomes more evident when you're able to scroll up and down. You can see that there's a whole lot of signal loss and blurring of the gray-white junction. And in retrospect, yeah, it was there. It was cut out, and there was a focal cortical dysplasia. Just showing you a pattern here. This is a different patient, kind of like the mirror opposite of the patient I just showed you. And again, you can kind of make out what your eye is looking for is that gray-white indistinction. And that look at the finger of white matter here. See how you lose that as you start going through that region. 24-year-old male, all previous MRIs read as normal. And probably in retrospect, you can see that things were kind of busy in this area. With the high spatial resolution and contrast to noise in this patient, we were actually able to see that there was a cortical malformation in this area. So this is one of the conclusions or themes that we've seen, is that there's increased conspicuity, these lesions I've just shown you. And that's just as valuable as the de novo appearance of new lesions. So that's very important. I'll just say it again. And this was a bit of a surprise to me when I started looking at 7 Tesla, because I kind of thought 7 Tesla was a new dimension and you're going to find lesions in 7 Tesla that you'd never see at lower field. And that's actually pretty infrequent, is that you can go back and almost always see that there was something there previously. And you'll ask, well, why didn't we see it? And that's the idea of conspicuity. As a radiologist, when you're scrolling through the images, it's just as important if something has enough contrast that your eye catches it, and then you can say, aha, there's a lesion. And that's just as important as having a technology there that just might show you there's a brand new lesion. This is one of those counterexamples, and this is one where honestly, and I'm not trying to window these in a way to fake you out, but that 3 Tesla just does not show that transmantle sign. And the 7 Tesla, you could see this dark streak that's running across here. And it just really, it's kind of startling. I don't know why I couldn't see it at 3 Tesla. But that's one of the few examples where I'd say that there was like a de novo appearance of something. 26-year-old male with epilepsy. Now, they knew about this one at lower field as a suggested left frontal malformation of cortical development. This is a 3 Tesla compared to a 3 Tesla flare. Now, this is the 7 Tesla. It's a T2 star GRE. And I think the next slide just blows that up. And you could get exquisite detail here of the relationship of the subcortical abnormality with a bit of a transmantle, white matter tail here. And it was shown on pathology, the balloon cell dysplasia. And the other important thing here, and there's another conclusion we'll have at the very end, is not only is seeing the lesion or identification of the lesion important, for the surgeons, it's also useful that it shows you margins and maybe where to cut and to resect way out here, to resect closer. And so that's another thing that we found that 7 Tesla's help is helping to define margins. And I'll show you some other cases coming up. What about something else besides focal cortical dysplasias? Here's periventricular heterotopias. And I would say here, in all fairness, you can see them quite well at 3 Tesla. But you can see that the contrast, the conspicuity is going to be greater at 7 Tesla. Here's polymicrogyria in this patient. On the left-hand side is a 3 Tesla, and you can kind of see the classic, grape-like irregularity of the cortical areas probably extending over here. And this was also important for the surgeon, and you can see it here even better, maybe the extent of it. Again, as you could scroll back and forth, it become more clear, this cortex here is normal and kind of normal, but somewhere around here starts to get suspect. Another example where the use of the 7 Tesla wasn't an identification of the lesion, they knew it, but was the surgical extent. This is this is another 7 Tesla patient that's got polymicrogyria. And it was noticed before at 3 Tesla, and you can see it here at 7 Tesla very nicely. You can see that irregularity here. But what hadn't been seen was that there was a contralateral lesion. In fact, if you look over here at the 7 Tesla, you can see the irregularity. And that made a difference in this patient's care, the fact that there are bilateral lesions and how they're going to try and investigate it. So this is kind of another theme, is that with the 7 Tesla, you have a higher probability of seeing other things that might be going on. And often these patients, with these abnormalities, it's not just one thing. This is a subcortical band heterotopia with known polymicrogyria. And you could just see it so much better. I don't think the subcortical band was appreciated, but it was called on the 7 Tesla. 25-year-old male, epilepsy since the age of 5. They'd known about this for quite a long time. It was pretty obvious at lower field. And it was thought to be a large dysplasia. But when we did the 7 Tesla, we could see the lumpy, bumpy irregularity of polymicrogyria. And that changes things a little bit in the treatment of epilepsy, that maybe there actually is a surgical option that you could have. Rather than a widespread dysplasia, it's a wider spread polymicrogyria, which often has more of a focal source rather than a diffuse source. So that made a difference in that young person's care. Here's another lesion, a hypothalamic hamartoma, 44 years old, and has many years of epilepsy, and this was never seen. Okay, very subtle. They got the 7 Tesla, and this is an example of the increased conspicuity here. It was able to be called. This patient is not, at this point, is not opted for any treatment. So let's talk about some things that maybe aren't epilepsy, because in all fairness, I want to be open-minded about where does 7 Tesla work and not work. And this is some counterexamples, which is still useful. This is a 19-year-old female, had right hemispheric seizures, and they had known about these this lesion here, and almost like it's connecting to the cortex there. And when we put them on the 7 Tesla, and you could scroll back and forth, it became very apparent that the cortex was actually normal, and there really actually wasn't a bona fide connection to the cortex. It just looked like it, and the high resolution was able to help us. And so we were able to conclude that this is some other nonspecific ischemic event or vascular abnormality, and we could focus the attention on surgery and lesions elsewhere. I remember this case, 28-year-old male, new seizures, and he came here for lobectomy and for this enhancing mass. So you can see what's, the concern here is a cystic thing, and it's got this periphery of enhancement. And so we did a 7 Tesla on him, and you could very nicely show that there's a very well-defined cyst. Oh, I didn't have the slide here. What it was shown was that the enhancing on the post-contrast T1 was really the choroid plexus being splayed around the cyst, but it was not a part of the cyst at all, and they canceled the biopsy. This is a 22-year-old male, NF1, and had some recent episodes, and so we saw this lesion in the right frontal lobe at 3 Tesla, and we got it at 7 Tesla. You can see it there, kind of well-defined, not really sure what it is. And then here on these, my favorite sequence, the 7T2 star, you can see that maybe there's some abundant vessels that might be going through it. And honestly, after we did everything and consulted and talked, we just don't know what this is. And it's stable over 2 years. So it's just an example that 7 Tesla doesn't necessarily solve everything. We've had many cases that are like this where we hope that the 7 Tesla will show us something, and in the end, we still don't know what it is. There's another one, 16-year-old male, and he had a concussion and a possible seizure. And so we saw this lesion here in the midbrain. We thought, aha, we'll get a 7 Tesla and look at that one and solve the problem. Same kind of thing. We don't really know what it is, and it has been stable. I don't think we've seen him in about 3 years or so. But another example, I'm just not sure what it is. You can see it. It didn't give us a lot of help. So MTS, mesotemporal sclerosis, we can do a pretty good job clinically, even at 3 Tesla. Some of the 7 Teslas, this is actually not a very good image, are very exquisite. I just put this one up here to show you the signal dropout that we get inferiorly in the temporal lobe. And this causes our epileptologists a lot of concern because they'd like to really be able to interrogate and see the entire areas of the temporal lobe. So we've actually found a drop off in interest from our epilepsy colleagues for the cases of mesotemporal sclerosis because they want to be able to see more of the temporal lobe. We'll talk about that. It's coming up. 21-year-old female, seizure since the age of 8. This is now leading into another weakness of 7 Tesla at the moment. And 3 Tesla, barely see it. It's 7 Tesla, and trust me, if you can scroll back and forth, you can see a little bit of this black line, which Dr. Wong will talk about later. It's very subtle. But this really caught my surprise. Look at the left. It's pretty clear, right? You can see there's a lesion there. That's a 3 Tesla. That's a 3 Tesla flare. Now look at the right-hand side, 7 Tesla. There's the 7 Tesla flare. And to be honest, I think everyone in the room, we agreed the 3 Tesla was better on the flare than the 7 Tesla. This flare sequence that we had here wasn't very helpful. I think this is the same patient, just another example. You can see clearly, in particular, if I window a little bit more, this brighter blob on flare, and at 7 Tesla, it's inconspicuous. This is the same patient, just in an axial section. So this is a bit of a disappointment that 7 Tesla actually, if we had relied only on the 7 Tesla, we wouldn't have seen this lesion. Or we saw the other thing on the T1, the black line, but this really showed the lion's share of the lesion. This is a different patient, 21-year-old female, seizure since the age of 15. 3 Tesla, could barely make out an abnormality. It was called rather easily at the 7 Tesla. And this is one where the flare might help a little bit. You can see the black line here going through, and you get this signal abnormality extending past it. So that was one case where it did help, but we could also see it on the other sequences. 13-year-old female, seizure since the age of 4. And they knew about this large dysplastic lesion here in the left anterior, the medial part of the frontal lobe here. And I'm blown in here. It's probably hard for you to see it, but there is this white matter signal abnormality extending past that. And so here's the T2 on the right, the 7 Tesla. I should say T2, not flare. And you could barely see this area here, but what you could see better was this subcortical signal abnormality in this black line. So that came out quite well. So this was a case where this helped to change the patient's management, because at first they were very prepared to just do an investigation here of the medial frontal lobe. This showed, we have to also put some electrodes here in the lateral part of the frontal lobe as well. This is an 8-year-old drug-resistant seizures falling asleep. Again, same story, all prior is normal. And 3 Tesla, this was never seen. At 7 Tesla, we saw that, and this child's been free after lesionectomy. One of the other big problems is the encephalocele. So here at 3 Tesla, you can see this temporal lobe encephalocele as the brain is getting pulled down here through a defect in the bone. And these are very easy to see and to treat if you can resect this part of the temporal lobe. But I would defy anyone to be able to try and diagnose that here at 7 Tesla, because there's just too much signal loss and low signal to noise that you get in this area of the brain. So the big question here at the bottom, will PTX, parallel transmit, help with that? So this is the promise of trying to address some of these as parallel transmit technology, which we have here, but it's not FDA approved yet. The next version of this Siemens Terra will have that for these MP-RAGE sequences. But this is just to show you, this is the same person, line these up identically, just to show you what it would do. So the single transmit, you can see all the signal loss that you're getting here at the mouth. You can see the cord, but there is lots of signal loss as you go down the cord. But just look in comparison to the floor of the mouth and to the cord, which is, it's still a little bit of drop off, but it's not nearly as much as it is here. So you're really able to boost the signal from these areas here. In terms of the inferior temporal lobes, single transmit here is on the left-hand picture on the patient's right, in that circle. Again, it'd be very hard to try and sort out the gray-white distinction that's there. And it's improved. It's not perfect, but it has certainly improved. And I think that this is a relatively recent new technology, and I'm going to suspect that as the years roll by, this will just get better and better, and we'll be able to really make this a marvelous instrument. In terms of the flare, there are indeed some new tricks out there to try and optimize the flare sequence, including the use of universal pulses. So these are both images done with parallel transmit technology. This is a standard space. And here you have the UP sequence. And again, it's improving things, and you're getting a better gray-white distinction in this area. But I'd also say, is it this one here? Well, this shows it was all. Then with improving the sequence, look here at the gray-white distinction on this flare, and it was just fuzzier beforehand. There are other areas. You can see the cerebellum, the folia are just so much better visualized with the universal pulses and less down here. So I think these last 2 slides is just sort of an answer to the problems that I showed you, where maybe 7 Tesla is having trouble helping us. But I think there's a lot of excitement for the future and other ways that we can address some of those things. So in the very end, this, we published with Irene, oh boy, 4 years ago now, our experience. This was with 67 patients, and we found that if we did a comparison of 3 Tesla to 7 Tesla on non-lesional patients, in other words, patients that came to us as non-lesional, that 7T yielded about 22%. Or to phrase it again, in 22% of cases that 7 Tesla images someone with a previously thought normal study, we find something. Now you might think it's a mild number, 22%. It's not a big fraction, but if you're in a program where you're scanning 100 or 200 of these patients a year, that's a significant fraction of people that are now walking around almost essentially cured from epilepsy just because of the 7 Tesla. So in conclusion with that, it's a small but important increase in 7T being able to help you. And here's the other thing that I had mentioned before. Retrospectively, when we looked at those, if you went back to the 3Ts, you could see something there 80% of the time. What about on non-lesional patients, patients that we knew had lesions? And about 28% of the time, 7 Tesla found other things in addition to that. And they could be hippocampal sclerosis that was associated, or maybe a contralateral lesion. Again, it's a small number, but in a big program, it can make a difference. Okay, so let's clock here. Okay, go to multiple sclerosis. So many of you have probably seen these. This is a fun slide I put together at one point. Same patient. co-register them 1.5 Tesla to 3 to 7. And you can kind of see the increased conspicuity you have there, all these white matter lesions. But really, where's the power? You've probably all heard of the central vein sign, which really helps to distinguish a multiple sclerosis lesion from nonspecific white matter change. And there's a whole criteria, and this is getting growing acceptance even in this year for helping to diagnose, because there aren't too many things that will do this preponderance. But you can see here on the left at 3 Tesla, you can just barely make out, and I don't think you could make it out with any diagnostic certainty, the 7 Tesla because of its increased spatial resolution. And on this sequence in particular, the T2 star GRE, it really shows you beautifully that juxtaposition of a white matter lesion and the vessel going through there. Here's just some other examples here comparing the 3 to the 7 Tesla. This is some examples here of how we actually might use it in clinical practice. You can see there's a little guy here at 7 Tesla. See, there's a little dot in the middle of it. And there's another one over here. See that? I think the next slide is a blow up of those lesions. And so that's able to help us to distinguish. Well, I'll give you like, what's the clinical conundrum? Because we're a big multiple sclerosis center. Is you'll have patients that have several years of mental status changes, and they get an MRI and they have a few white matter spots. And it's very difficult for the clinicians to adjudicate what might be the cause of the patient's symptoms. Are these just nonspecific spots, or could these be multiple sclerosis lesions? They don't often come to us full blown like this. They often will come to us in this day and age, things like this. So this becomes very important, being able to look at these small guys, and there may be only a few, to try and help the diagnosis. This is a counterexample. This is a patient, as I just described, and no central vein was seen anywhere throughout the brain. And, oh no, this is the same patient, but it's a counterexample of a lesion, showing that this one here did not have a central vein sign on this one here. Vascular abnormalities. As a 54-year-old female has an aneurysm from the internal carotid artery. And we've had a number of referrals for this particular question. They know there's an aneurysm near the ophthalmic origin. What is its relation to that actual vessel? So on the left-hand side is a catheter angiogram. And you can beautifully see here the ophthalmic arteries coming off, and you can nicely see the aneurysm that's there. When we do a 3 Tesla time-of-flight MRA, you can't really see the ophthalmic artery very well. You can see the aneurysm quite well. And this is just to show you that the 7 Tesla was beautifully able to show a little dropout here where the ophthalmic is, and the physicians were able to declare by scrolling back and forth very carefully the relationship of these two, and it makes a difference with the treatment. 44-year-old history of CNS vasculopathy, not of uncertain type. They've had multiple strokes. They had a bypass. And you can see in this angiogram on the right is recapitulated quite well at the 7 Tesla MRA. This is now getting into the realm of vessel wall imaging. So here they had a 3 Tesla vessel wall imaging, and there's a suggestion of a central channel here, but this is exactly a great example for how 7 Tesla high spatial resolution makes a big difference. Because you could see here the vessel coming through, it's stenotic, and you've got vessel wall thickening and enhancement with remodeling inward. And you can't really make that out very well. We could see the enhancement there, but this was really able to help the docs figure out how to treat this. What they often look for is this donut sign, where you go and cross section to that, and you can see there's the central channel, and you've got basically the circumferential enhancement and thickening, and that helps you to distinguish it maybe from things like atherosclerotic disease. Is this the same patient? Yeah, same patient, and you can see in different areas. It's very hard to make out here, but you could suggest at 3 Tesla that there was abnormal enhancement here. And certainly at 7 Tesla, you can see this tram track sign, and it's just a slam dunk, about to diagnose that. This young man had a number of little strokes. Here's a stroke on the left, and it was an enhancing lesion post-infarct. And at 7 Tesla, and I'm not going to show you the 3 Tesla slides, there was an abnormality right here, almost like a little bit of a web. It was, we had the resolution to be able to see that. On the vessel wall imaging, you can see, yeah, it's stenotic, and you've got this tram track sign here. And when you went perpendicular to that, you can see this feature, this web that was sitting in there. And this was most likely a dissection here of the right M1 of the MC vessels there, and was not atherosclerotic vasculopathy. And that turns out to be a big distinction, whether it's atherosclerotic or not atherosclerotic, because very powerful drugs might be administered or not. So this was another, we get these, several of these cases a month trying to assess exactly the sign. Just to show you there was a vertebral artery, this enhancing lesion on this patient. And this is just for fun. I mean, you could see it stenotic here on axials, but I've never ever been able to do this before, which is to do a curved reformat of the basilar artery. This is just a few millimeters across. And doing this curved reformat, you can see the stenotic segment that was there. So just to show that, increased spatial resolution can make a difference. 21-year-old female had a large brainstem AVM. And this is just kind of for fun. This is the catheter angiogram on the right. And you can recapitulate that quite well with the 17 MRA. But this is the movie. This movie was playing at the very beginning. Just look at it for a second. This is a very complicated AVM for treatment purposes. And our skilled surgeon here was able to scroll up and down and really study this 7 Tesla MRA to help plan what was a very detailed and I think multi-procedural treatment of where to go in, where to clip, where to put some onyx material to embolize. So he loved it. Okay, 10 minutes. Okay, a little different tact here, just a couple fun stories of things that we didn't expect. This is a patient that had MS, and this was, they were getting 1.5 Tesla, and they were on these powerful immunomodulators. You can see here, we'll just call this the index time at month 0. And this is pretty classic for PML to start. And if you went back 2 months, it was not called at this point, unfortunately. It was not called back here, back here. And I think on months 22 and 16, it just wasn't there. Okay, so I get a 7 Tesla. And the 7 Tesla saying, okay, well, that's nice. We're kind of recapitulating it. But then you got the T2 star GRE. And then this is what we noticed, was that there's very strong, look at that signal loss here around the cortex, or gray-white junction. Now here comes the really cool part, is when we go back and we look at the earlier flares, like one that was 6 months. Remember how I showed where it was starting here and starting there, and as time went on, it started to coalesce. But where it started are these areas here where you have a lot of signal loss. And so we wondered that could these areas actually represent older disease, that it might have actually, this is a sign of PML and where it's starting. And this was at, say, month 0. And this is 2 months later, we get the 7 Tesla. And you can see where it was starting here. You've got the signal loss like we just talked about in the cortex. But we also noted on the contralateral side, you can see this area here with some signal loss in the cortex right there. It looks black. But if you look, there's no corresponding problem with the flare at that location. And look what happened. This is now 1 month after the 7 Tesla. It was starting to brew here too. So, we wrote this up, and it was really kind of interesting that, this might be one of the very first signs of PML starting, is to actually get the 7 Tesla T2 star GRE and look for areas where you have the signal loss in the cortex. And this is a patient that had more advanced. As with the high resolution, you can see what kind of surprised us, where the actual darkness, this line, the disease, is sort of right here at the gray-white junction. It seems to almost be at one of the most internal levels of the cortical layers. Oh, this is a great case. So this is a 64-year-old female. They had progressive mental status change. Okay, so this is a 3 Tesla, and oops, oh, there we go. And you can see multiple lesions, and a radiologist should easily be able to pick this up and suggest this seems like cysticercosis. Okay, just on these multiple little cystic things, but it could be other things. So we got the 7 Tesla. On the bottom's the 3, and on the top's the 7. And you can see the Scolex. You have the resolution to see not only the cyst, You can see these little calcifications that might be here as part of the parasite. Here at this SWI, I still like the T2 star GRE. And so they did, and the patient also, had other lesions that were in the lung and other organs. This is just some other examples. This is all 7 Tesla. Well, it's kind of not showing very well on my screen here. These mineralizations, these dots, that dot there, that dot there. And so this was really able to make us think this is a great thing for 7 Tesla, that we're actually able to show the classic kind of calcification that you see in these lesions and really nail it as cysticercosis. But all the cysticercosis labs came back negative. Then they sent off all the material to NIH. And about 2 months later, it came back that it was Versteria, which is a cousin of cysticercosis. It's a zoonotic cestode. And it turns out that the patient's husband was a taxidermist. And so the thinking was that somehow there was some transmission from his taxidermy work and infected his wife with this. So this was one of the first diagnosed cases of MRI showing Versteria. It's a very rare parasite. Okay, ex vivo, and we're almost going to be finished here. This kind of fun stuff, a little different. So this is an ex vivo brain. So, we've got techniques that we can make the resolution down to 170 microns cubic. It does take 48 hours. And for us, it's really, it's not a lot of skin in the game because the scanners are never really working on the weekends. And so we can get these samples and prepare them. And it's not easy to prepare them. You got to get rid of all the bubbles. A little tiny bubble just blooms and makes a big spot. And then we try to get all the water out and replace it, with something that gives us, this black technique. And just sits there and we scan it all weekend long. And you can get these exquisite pictures. Just look at the beauty of the brain. You just see all these structures come up. So the next thing that you can do is you start wondering, let's look at diseases with this. Well, this is a normal person looking at the entorhinal cortex. And you can see the normal thickness that you might have there. This is a patient with Alzheimer's. And you can see here, you get this thinning of the cortex, very different from what we saw in the previous patient. And here you got the normal thickness there. So this isn't anything new, but this is just, it's interesting that we can try and relate pathology with these ex vivos. This is a patient with Alzheimer's, and you can see all these cortical microhemorrhages. And these are, our neurologists really love the concept of being, cortical microhemorrhages as being diagnostic for Alzheimer's disease. And at lower field strength with higher spatial resolution, we just almost never see them. And the pathologists will say, well, they're there. So this is just a nice confirmation that in this patient here, and this is the blow up of the insula. And trust me, these aren't vessels. As you scroll back and forth, they have this peppered, intermittent look. Those are chronic microhemorrhages. Then you can have lots of perivascular hemorrhages in this patient here. Other perivascular hemorrhage. This was a fun one that we didn't really expect. You see that vessel, there's a blow up right here. They have that corkscrew appearance. I'm not really sure what to make of that finding, but we've heard people tell us that can be very helpful for diagnosis of some degenerative diseases. Just another, look at the vessel down there on the lower left. Here's a blow up of that. If we just do a double oblique, and this was just so much fun, you could see here in this extracranial vessel, a luminal plaque. And I'm not sure what the use of this is, but we're exploring the capabilities of trying to look at the brain in a disease in a parameter space that we normally don't look at, where you can see the whole brain with high resolution. We've also gone to look at multiple sclerosis lesions and the purported paramagnetic rim sign, which I think, we can sometimes see with a lot of scrutiny, but we're able to see it here on these specimens right here. And this is with work with Dr. Obazuz, our junior colleagues. And just kind of fun to see here what multiple sclerosis lesions look like. All this dark band here is just devastating MS in this patient. And it's kind of fun too, as you can see these plaques, how they sometimes can grow out and they seem to not respect gray-white boundaries, kind of as I had thought they might. Again, if you can scroll back and forth, you get an appreciation of these lesions sitting there, and we'll dig into cortex more than I thought that they would. Just showing you the thalamus, and you can see the beauty of the structure there of the thalamus, all those nuclei. And it's kind of fun to lay this up here this is for planning purposes, trying to use these scans for DBS trajectories and not just flash that back and forth. just like the textbooks show, you could really line up and match those nuclei. What could be other future targets? You know, I think the pituitary gland is a home run. If we can just deal a little bit more with some of the variability we have in patients and the susceptibility effects that we have there. I think it's a home run to look at the cranial nerves to see the details, you know, maybe trigeminal neuralgia. Again, with the new technology, if we can just boost the signal a little bit in this area of the brain, because the sphenoid sinus can often just really knock that out. And just a thought experiment, you know, I think, you know, what if in the decades to come, we could routinely get brains with resolutions like this? You know, how would MRI disrupt our clinical practice? You know, now the training, you'd have to be able to know all these structures and what they do and what they look like in various diseases. So I think it's very exciting for the future as to where this might go. So let me just conclude some lines here. And I just want to emphasize more. 7T shows mildly more lesions than 3%, 3 Tesla. Remember, I think it was 22%. But in a busy practice, 22% may seem small, but there's a lot of people that can benefit. There's increased and number 2, increased concept acuity is just as important as de novo visualization. And this is just that it's easier. If you make it easier for the eye to see it, that's very important. Number 3, 7 Tesla can improve visualization of the extent of lesions, and the surgeons find that very important if they can get a more accurate demarcation as to where the diseased tissue is. Number 4, 7 Tesla can also show other lesions, as we've shown. And 7 Tesla can also do the opposite. It can also help to exclude what might be thought to be epileptogenic lesions. And I also just want to put a reminder of Irene's talk with on the 4th of May. What about other future possibilities? I got 2 slides here of things that are dear to my heart. This is just for fun. This is using 7 Tesla with a paradigm-free mapping. This is tapping the right-hand finger once every 30 seconds or a minute. And you can make these maps of the propagation across the brain simply due to a single finger tap. Okay, well, that's cute. What's the point? The point is epilepsy. Is that if we were to hypothesize that maybe an epileptic spike could have the same kind of a bold response as a single finger tap, could we see anything in the brain that might help that? So this is from a patient, an epilepsy patient, and this is a movie over, it's very fast. We run at TR 300 seconds. But this is what excites me is you can see here in the brain, areas of the brain kind of flashing in and out of activity on a bold sensitive sequence. So it's still a lot of work to try and sort out what's real. There are lots of false positives and false negatives, but I think this is great for epilepsy in the future. So when I'm trying to explain in the very end here, 7 Tesla, I always think of it as the old days when we had those cathode ray TV. And this was, and I did this, when did I do this? The 2018 World Cup. So on the top was the old cathode ray TV I had when we were watching the World Cup game. And here's now I put it next to my new high definition LCD. So I always think in a way of 7 Tesla as like high definition MRI. And often you can still enjoy the game. I mean, I've spent decades enjoying football games and baseball games on my old cathode ray tubes. But boy, isn't it nicer when you can actually see things like you can make out the scores and capture all the other details. And I think that's the same thing for 7 Teslas. That you can do an awful lot at lower field, but sometimes that higher definition does pay off and does make a big difference. And I think I've shown you in epilepsy how that can do that. So that's all, folks. And of course, this is done with the help of an awful lot of people, particularly Irene Wong. And I'll finish there and happy to take questions.
Thank you for this amazing talk, Steve. This is really great. Beautiful images, as you said. I especially like the last image you showed during the ex vivo, section. Someday if we could achieve that kind of resolution routinely on 7T, that'd be great.
Yeah, wouldn't that be? That would change everything.
Right, great. So as usual, we have a Q&A session. So for all the attendees, you can either use. I prefer you use the Q&A box to put to your questions. Then I read the questions. Or if you cannot do that, you can also do it in the chat. And Dr. Barker is here. Peter, you are a panelist, so you can just speak if you want. Oops. Peter, are you saying something?
I'm not hearing anything.
Right. Yeah, I heard Peter talking, and then for some. Oh, so we got a question from Ahmed, and Ahmed is actually a clinician here and who's very interested to do 7T epilepsy. So hi Ahmed, thanks for joining us. So he said, a great talk. How often would you find important findings on 7T without having clinical knowledge from other tests such as semiology and EEG?
That's a great question. And I'm going to admit, in the paper we published that had where we said 7 Tesla showed 22% increase, it's hard to do what would really be a proper control experiment on that. And that would be to just repeat the study at 3 Tesla, because there's just a known fact that anytime you just have another pair of eyes looking at a scan again, you'll often see more things. So if we had replaced the 7 Tesla with a 3 Tesla and redone all of those patients, maybe we would have increased it 10% or so. And his point's very well taken. And every week when I sit in the epilepsy conference and I'm listening to a complete description of the semiology and the EEG and even the MEG now, that does help to focus my attention quite a bit on particular areas of the brain. So it might be hard for me to quantify that, but there's no doubt that the searching does help at any field strength to know a little bit about where things might be happening. Because it's too complicated. Remember, the cortex of the brain is about the size of a sheet of newspaper that's all crunched up into a small ball. And for epilepsy, you want to interrogate that entire surface area somehow, ideally. And so it gets very hard, sort of like, where's Waldo? Trying to find the lesion in that as you scroll back and forth in window. And it does help to know a little bit about where it might be coming from, even a side, is it right-sided or something? I'm not sure if I answered the question.
Yeah, that sounds great. Ahmed, if you have further question, you can type, or if you prefer to speak, I can promote you as a panelist. Just let me know. So the next question from Kenichi, Kenichi is a faculty here who we've been doing some ex vivo scans. We tried to do some ex vivo scans as well. So I'm sure he is amazed, by your ex vivo images. So Kenichi has a question. He said, can you tell a bit more detail about the method to remove air bubbles in ex vivo studies?
Oh, yeah. And if you want to, we can send a paper that we'd had, I think we bought our stuff from Amazon. So what are the kickers? Kickers are, got to get rid of the bubbles, because you can see here, like in this image here, if you have even a little bit of air, say in that ventricle, it will bloom very much so on the 7 Tesla, and this kind of ruins that. So the way that we get rid of it is we put the brain under, I want to say underwater, but I think we use the Fomblin, which is just MRI dark agent, and we put it under vacuum. And then we found that to speed it up, basically we boil out the bubbles that might be there, and we have a shake table. And I think it's a shake table that, again, from Home Depot for $90. So under vacuum, we put the whole thing on a shake table, and to jiggle things around to try and increase basically the diffusion. We boil, we suck out all the air from the liquid. So that's one key. Shaking it under vacuum, and I think we have a recipe, it might be about a day and a half to get all the bubbles out. Then it turned out the other problem is that you put it in the MRI, and you're looking at 170 microns. Well, if the brain moves over the weekend, like if it moves more than 170 microns, you're kind of defeating yourself that you're losing that spatial resolution you can get. So it became kind of figuring out some techniques of how to hold something like that over a weekend, still to within 170 microns. And so we wound up doing some 3D printing of a brain holder. And they're just kind of little things, like you put something from the top and from the side and on the bottom, and little details like that. So I think those are the big ones, is using a formalin, an agent to make the water dark, getting rid of all the bubbles, and securing it so it doesn't move during the very long scans. The other problem we had is that there's a problem with our magnet, is that when you're running it that long at those gradients all weekend long, we burned out 2 big cables. Now, it turned out that it was not really our fault. It had to do with, there was an installation error. But still, when you have a clinical piece of equipment, you're burning out gradient cables, that's not good. So it does tax the machine. Another thing you got to be careful about are memory requirements, because there's you're running it so much that the memory, you just keep putting these images into memory and it can blow up. I forgot to mention that one.
Yeah, that's right. And Kenichi also asked, have you experienced effects of blood iron inside blood vessels in ex vivo images?
Let's see. I think I might know what he's talking about. Look here. You see the white lines here?
Mm.
Sometimes you get black lines. I've never really been able to fully understand the difference. And sometimes you can follow them as to white and they turn black. Or is it, and what I don't know, is it a perivascular space, or am I seeing something about blood in the vessel? So it's a great question. I don't really know. And I've been trying to get my pathologist to can we agree that we cut some section exactly where I see that, and look under the microscope and tell me what you see. So I don't really know, and I'd be happy to hear his thoughts, if he thinks that some of these black things could be residual iron that might be there. That's always just an imaging question. Why is this dot black and this dot white? What's really going on?
Right. Yeah. I also have a related question for these ex vivo data. Do you have planned, or you probably already doing that, to share some of these images?
Well, no, absolutely. It took us a while to develop this.
Right, of course.
And so some of these brains were donor brains that were, I think, 3 or 4 of them we had that were normals, that we had to try to just test out the system. Then, what we're interested in is the rad path correlation. So I think you've already got numbers of papers out there. We're not the first ones to do this, that can show you a normal brain in this exquisite detail. So we're trying to do, what's the next step forward, is how do we show abnormal brains with this method? And that's why the emphasis on some of these diseases. And we have, there's Emmanuel. And then Emmanuel had a ASNR grant, a prestigious grant from them to basically do the rad path correlation. So he's just finishing this, and we had 10 brains with multiple sclerosis. And it's to exactly do things like identify this, and this is harder than it sounds, is to get the pathologist to also at that exact same location. Because you know how pathologists they'll get brain tissue and they'll take these 5 or 10 millimeter sections, and they'll use the knife and cut the sections regardless of where we want the pathology. So the slice might go through here, it may not go through there, or it'll be in a different plane. And so trying to get that to match up so we can have this exquisite rad path correlation is a desire. And so certainly we'll publish that.
Great. Oh, we have lots of questions coming in. So again, from Ahmed, thanks, you certainly answered the question. In your opinion, what is the most valuable signal of focal cortical dysplasia on 70? I find 70 to be challenging because there's always a period of getting used to the fine details and the higher signal before being able to tell what is hyperintensity versus normal signal on T2, especially. This is the first question. And he also asked a second question. I want to group them together. Sorry about that, if you're okay with that. A very general question. What resources are out there for an epileptologist that can help them learn how to interpret 70, besides talking to the neuroradiologist, of course?
Yeah. So the first one about what sequence do I like? Personally, what I like is the MP2 Rage, or maybe sometimes now the MP Rage, which is much improved from the Magnetom to the Terra. just because the signal to noise, the spatial resolution is so good. And then I'm really looking for the smoothness of that gray-white junction, like I showed at the very beginning. And I wanted to show all the warts as well. And I tried to show you how the flare imaging on the 7 Tesla is suboptimal, in my opinion, at the moment. I don't think I've ever liked it, but also I've seen it since 2013 become much better. I mean, the volumetric flares that we used to have, say, 10 years ago, they weren't very good. And I think they're getting much better. In terms of training someone, I think the surprise for me has been that it's not as different as I thought. Now, we have a group here of about 26 neuroradiologists. And long ago, we realized that when we started doing this clinically, we weren't going to have a specialized subsection that are the 7T specialists. Because once you kind of, took this car out for a drive and you drive it around a little bit and you get used to it, it wasn't that different, actually. Yeah, it looks a little bit different, but it wasn't significantly different. And we have now all 26 of us. We all do the 7 Tesla. And at first, there was lots of consternation. Oh, they look different. I don't know if I can do this. But actually, when you just roll up your sleeves and do it, it wasn't that hard. And so I think I can't offer a lot of tips, but if someone wants to email me or go over some cases, I'd be happy to do that as well.
Wow, that's great. Thank you. And then we have 3 questions in a row from Doris Lin. So Doris asked, what is your workflow? Are 7T scans part of your clinical workup or for research only?
Good question. So we have the way it's set up here formally is that we spend half the day for research and half the day for clinical care. So in the morning, we have 4 slots. We make them 1-hour slots compared to I think with the research slots are more ill-defined. And in all honesty, those 4 clinical slots, they're underutilized. We probably use about half of them, 1 to 2 a day at most. And so that's kind of a little disappointing on my part because, I went to all the trouble to go to our board of governors and convince them to spend all the money on this important instrument. And, to find out, well, why aren't we doing more clinical with it? And I think, and I speak in all honesty about this because I think a lot of it's culture, and changing cultures is hard. That if you have, for example, let's say in oncology, you have a bunch of surgeons and neuro-oncologists that are used to looking at brain tumors with 1.5 and 3 Tesla. Getting them on board that 7 Tesla can help them out a lot. It's hard to get that change to come through. They're creatures of habit, and they also will think 7 Tesla must be something kind of crazy and science fiction. I don't need it, or I don't understand it. So I'm exaggerating a little bit, but just to make the point that even amongst my colleague clinicians, 7 Tesla can kind of seem like it's something very differently and outworldly, and maybe we don't go there. So we're hoping to ramp that up more and more and try and convince our colleagues that we can do all sorts. An FDA-approved machine. We could scan all sorts of things, on it. It's not just for research. It brings up another point. It's like, how does 7 Tesla, how should it fit in with other scanners? And I think at the first I was envisioning it as a problem-solving instrument. So what did I mean by that? Is that, let's say you have a patient coming into the clinic and the doc says, I think we need an MRI of your brain. Well, should 7 Tesla be the very first go-to scan? And I don't think so. I think that you would use it for problem solving. So you might have someone like these epilepsy patients, they've gone through MRIs multiple times and nothing has been seen. Well, let's look at it now, in a slightly different way with higher spatial resolution and see if we can answer that question. So seeing it as a problem solving instrument rather than the first go-to image, I think is a reasonable start. Again, I veered off in my comments. I'm not sure if I answered the question.
Yeah, I think that's great. And Doris also asked, is the 7T GRE done as 3D SWI? Do you get face images as well?
We do get the phase. I don't look at the SWI as much as I like the T2-star GRE, because it gives me, for me, it gives me better characterization of normal brain parenchyma with abnormalities. The SWI it's almost as though the the susceptibility weighting is too strong and needs to be tuned down a little bit. Because, you know, it's so strong that, you know, and I'll exaggerate here, that the whole brain can just look like a mass of vessels. So, you know, you're just scrolling up and down, seeing a mass of vessels because of all the black vessels. And that's not that bad, but that's kind of how I feel when I'm looking at it.
Right. And also Doris wanted to know if you have done some imaging in Alzheimer's brain in vivo and find cortical microhemorrhage as well.
We have not done that. Let me think. We do have a program. We have a research program. We put some Alzheimer's patients in there. But I can't recall that I've actually seen one of those images and said, aha, here's a cortical microhemorrhage. But I haven't looked that hard either.
Right, right. And we the last question we got so far, it didn't show the name. So so it says, great talk. I see that the largest application of 70 is now epilepsy. There's one technique called EDGE, EDGE, that I think is especially designed for epilepsy. And I saw in your slides in clinic, MP-RAGE, FLAIR are still mostly used. I wonder if EDGE or synthetic EDGE would be useful in clinic now.
Yeah, that's no, I know about that sequence, and also something similar to what pops out with the MP2 RAGE. And what it is it just really enhances that gray-white distinction and makes a black line along there. So some years ago, we saw this also with Irene. We got all excited thinking, aha, this is going to help us find those cortical dysplasias really, really easily. And then it just turned out that in practice, there were lots of kind of false positives and negatives. It wasn't super reliable as much as you would like. So it's one of these things, you know, in all of our careers, we encounter this where it sounds like a really great idea, but when you go and in practice try to adopt it, it just doesn't seem to hold up to what you had hoped for. In addition, that sometimes just simply looking at the normal gray-white distinction on the MP-RAGE was pretty good. We haven't given up on it, but, you know, maybe I should revisit it because this is not the first time in the last few weeks someone has brought this up. maybe I'm missing something and there's another sequence out there that's better. The concept is great. It's just putting it into practice.
Right. Opposite face information, right? Sort of cancel things out.
And the brain is so contorted and convoluted. So, you know, there'll be places where for whatever reason it skips or it accentuates, and it's more because of the convolutions of the brain rather than a lesion there.
Yeah, I realize it's already 12. I actually have lots of questions for myself, but I really just want to ask you one question before you go, if you don't mind. So, like I told you, we're very interested in you know, developing those PTX pulses. So I saw, you know, in your slides, you show some you know, PTX pulses. So, well, first I was wondering when you use you know, dropouts in the, you know, temporal lobe. Did you use the dielectric pads, or what's your opinion on those?
Yeah, and that's another one that's kind of similar thing with the black line. So we started off with the dielectric pads with a lot of excitement, like in 2013, 2014.
Right.
And I think there's no doubt that it does help, but I think what we found, what I found, was that it was very variable, and that we'd have some patients where you put them in there and it didn't seem to do much. You have some patients where you put them in and they do seem to help. And so it's kind of frustrating that way.
Right.
And, you know, I think, and you know, what are some of the variables? Some of the variables are it's a small head coil and people have different head sizes. So depending on how their specific head fits inside the coil, does their head go deep into it, or do they have a lot of the face still sticking out? You know, so you have these variables that just made it, I mean, as a radiologist, I want something more constant. I'd like to have the technology where I just know every time I get good signal there, and I don't have them come to my desk and the images say, well, we tried the dielectric pads and didn't work. So
exactly. Yeah.
I think in summary, I said a lot. I'd say in summary, they do work, but it's variable, and that variability is frustrating.
Right. So right now in your clinical practice, you don't use those pads. You instead use the PTX. I saw you show two examples. One I think it was a flare, and the other was a MP range. Oh, this one. So yeah, flare. You said that this is a universal pulse.
Yeah.
So is that so you use the universal pulse in the readout, or it's the inversion pulse in front?
Now you're asking me questions I'm not sure the answer to. This was hot off the press about, we did this 4 months ago.
Okay.
It was a test coming from Germany of someone's sequence to say, can we try this just on the research? So this, I'm not even sure. It might be a whip. I can't remember right now.
Okay. Okay. Yeah, this is amazing flare. I think it's very difficult to get good flare.
It's very difficult, and it's frustrating too. Particularly, it's frustrating when our epileptologists get upset at 7 Tesla because the flare is not very good. So, there's a lot of efforts to try and improve this. And I put this up here is for optimism that, I think some of these things are technically fixable, but better coils, PTX, some of these new pulse sequences, universal pulses, this is the first time they're trying it. So, maybe in 5 years, they'll really this will be even vastly improved too.
Right, right. In the previous slide, you showed the MP range.
Yeah.
This is the MP range. Yeah, this one.
Yeah.
This one's really great. So you said this is a parallel transmit. Is it also universal pulse or some other pulse?
No, this is just the technology. So this was the same, remember, this is the same patient with single transmit. And then I think, I'm trying to actually recall if this might be like what you mentioned at the beginning. It's a parallel transmit coil that we tie all of them together. So it's effectively like a single transmit.
Oh, okay. So it's a different transmit coil.
I have to go back and remember exactly what it is. And to say it again, the left-hand picture, I don't know if it's the same parallel transmit coil, but it's not being operated in parallel transmit mode. Or if we pull the patient out and change the coil and put them back in, I just can't remember.
Yeah, it looks like, the contrast is pretty amazing. So I wish we can get this kind of improvement on our scanners too, but we're still working on that. And I'm curious to see the new Siemens Terra X.
And I don't want to oversell it. I mean, you can even see here on the parallel transmit, it's still not, in this area, still not as good as probably a 3 Tesla.
Right.
But it's a lot better than that.
Yeah. Okay, great. So I don't see any additional questions. And it looks like Peter has some microphone problem. So he said that thank you so much for the great talk. I was gonna say the same thing. This is a really amazing talk with beautiful pictures. Thank you so much, Steve. I really appreciate that. Yeah.
And thank you for inviting me. And remember Dr. Irene Wong, who will kind of pick up the ball where I'm leaving it here. Yes.
Perfect timing for next month. And for everyone who is still here, thank you so much for attending and for staying so late. I really that, and we'll see you next month. Thank you again, Steve. I see you, I guess, in Singapore or later.
I'm going to see
at 70 a meeting Danny is organizing.
Yeah,
I remember last year we had a good time.
Yeah, it's fun.
Yeah. Thank you so much again.
All right. Thank you.
All right.